Hello, I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. Well, we're here one more time, and this night I would just like to emphasize sharing and caring. Remember, sharing our med moments, those moments that let us know that, listen, I should go see my doctor. That chest pain, that knee pain, that ankle that won't go down from the swelling, you just never know. It may be a medical problem. Go see your doctor. And also, share your med moments. Let me tell you, if you talk about your med moments with others, it may stimulate them to go see their doctor. So that's what it's all about, sharing and caring. Well, I so appreciate all of the emails and Facebook connections that I'm getting out there. Listen, website. We have a website now, and go to it. It has so many health tips, all information that's good as far as health is concerned. OBHealthy.com. Go to it, check it out. A lot of health tips. Also on Facebook, Obey Your Doctor. And Instagram as well. Instagram, we're doing a series on weight loss. So go to Instagram, check out the salads, check out all the pictures, and it just may help you lose a few pounds. Alrighty, let's talk. We're gonna talk about a subject tonight, and it's an important subject. It's called lead poisoning. And I just wanna take a moment just to cover this topic because it's a topic that affects our children. Alrighty? And when a child gets lead in their system, several things happen. You know, as they grow, they have a lower IQ, meaning that they don't learn as well. They have behavioral problems, growth problems. They don't grow to a normal stature sometimes. Anemia, meaning that their blood count could be low. They could get kidney problems or kidney disease and hearing losses. All of this can come about just because your child was exposed to lead. So it's something, if you feel that you have a house or you're in an area and the soil is contaminated with lead, let your physician know. Alrighty. There are other things that we must understand, that if you have a house that's old and you have a lot of dust around the house or paint chips are coming off, you should really let your doctor know about this because it could be affecting your child if that paint or the dust around your house has lead in it. All right. Let's get to the meat of our show tonight. Tonight we're going to talk about pulmonary hypertension. And basically, I have an excellent physician here tonight to cover this topic. He is Dr. Terry Anand, and he is Director of Pulmonary Medicine at Newark Beth Israel Medical Center. Dr. Anand, welcome to our show.
Thank you, Dr. Bey.
Yeah, definitely.
Thanks for this
Yes.
invite.
I'm so happy that you could break away from your busy practice and come and speak on this topic because it's a topic that, since I happen to be a pulmonologist, it's a topic that I see quite often, but it's a topic that others should know, the basic population should know about. Alrighty. So the first question is, and it's always my first question, what is pulmonary hypertension?
It's a condition associated with various diseases where there's a rise in blood pressure in the lungs. Mm-hmm. Just like what you have in the systemic side, this happened to actually the disease manifest on the vessels of the lung that causes the right side of the heart to work harder.
Okay. So, all right, let's. You said several things there that I want to see if we understand.
Yes.
When you say systemic blood pressure, what do you mean by systemic blood pressure?
It's the common blood pressure we typically see. Somebody has hypertension. You put a cuff on their arm and you measure the pressure. We know what the normal is, 120/80 for most people.
Right.
In this case, the pressure in the lungs itself, usually it's very low.
Okay.
As we exercise, do things, blood flows across easily. There's no rise in pressure that much. But what happens in these patients is narrowing of the blood vessels.
Okay.
A variety of different mechanisms, certainly different diseases are associated with it. But this narrowing causes the right side of the heart to work harder.
Right.
It's almost like a when you don't have enough tunnel channels for the cars to go through. If you narrow those channels, the traffic increases.
Right, it backs up,
It
right.
backs up. So in
Yeah.
the same case, it happens when you have to do activities. Your heart has to pump more blood, which is essentially what we call cardiac output.
Right.
It has to increase, but this narrowing doesn't allow the heart to be pushing blood into it.
Right.
So you really can't, it puts the heart in the strain, you really can't push the amount of blood you need to do that exercise activity.
Right, right. So let me see if I get this straight. We have the right side of the heart.
Yes.
And I'm going to ask you to take me through how blood goes through the lung and the heart in a minute. But we have the right side of the heart that's pushing blood into the vessels of the lung.
Correct.
And sometimes what happens is these vessels get narrow.
Correct.
And that blood, it's like a bottleneck then.
Yes.
And the right side of the heart is trying to push that blood through, and it bottlenecks down, so not much blood is going through the lungs.
Correct.
And then we obviously we need more blood, so we're having a hard time. And that's basically what pulmonary hypertension is. The vessels of the lung are kind of clamped down, and they won't allow the blood to go through easily.
Correct.
Now, is that associated with systemic or regular blood pressure, or the blood pressure being high in the lungs can happen without having high blood pressure in the rest of the body?
It's a separate entity.
It's a separate entity. Oh,
Yeah,
all right.
So,
all right.
People can have blood pressure on one side and not necessarily have anything here.
Right.
But more often these patients, depending on the condition associated with it, typically this is an isolated disease that is not related to the high blood pressure that we typically think of.
Okay. Now, step back just for a minute.
Sure.
Do me a favor. Describe how the blood goes through the heart, the right side, and then what happens after that, going through the lungs and then going back into the heart again. Describe that function of how the blood goes around.
So typically your body drains the blood through the veins, either through large veins in the head portion of it, what we call it superior vena cava.
Right.
Then from below, what we call the inferior vena cava. Both of them initially drain into the first chamber, is called right atrium.
Oh, okay.
And that's, it's a low pressure chamber, which allows the blood to drain into the right ventricle. Now, this is the heart muscle, the right side of the heart, that pumps blood through the lung.
Right.
You know, and from across the lung in normal population, it's very easily flows through.
Right.
And then comes to the left side, which is the left atrium, which drains into the left ventricle. This is a more muscular muscle that pumps blood through the rest of your body, your head, your rest of your body, lower extremities, and so forth. So left side of the heart is made, it's very muscular, it's made to pump blood. I mean, provided you don't have very high blood pressure.
Right.
For normal blood pressure, it functions quite well and pretty much lasts lifetime, if you want to call it that. On the right side, the chambers are thin.
Okay.
It was really made more of a conduit rather than really necessarily pump blood in a circumstance. But it pumps blood, and the resistance in the lung, or the pressure in the lung, is low. When the right side of the heart pumps blood, it's very easily pushed through.
Right.
Now, in people with high blood pressure, when this increases, the right-sided chambers has to work harder. Initially, it gets thicker, the pressures do go up, but eventually, as it progresses, the right side heart fails, and then you have no blood going through, and this is where a patient can die from what we call circulatory collapse.
Oh, all righty. So circulatory means that the blood's going through from the chambers, and so it's not going through each chamber appropriately, and it almost stops.
And
then,
if the heart muscle stops.
If the heart muscle stops, then we die. All righty. Yeah. So we're talking about a disease now that is can be very severe. I mean, we're talking about serious stuff here.
Absolutely. I mean, if you have pulmonary hypertension, and I think really, let me just briefly talk about what the disease associated with it to kind of understand. There's really 5 groups of that's classified into, and I'm just going to start with the 2nd, 3rd, and 4th, and the most important one is the group 1. The second group is really to do with heart disease, people with but the heart
Now,
doesn't.
when you're talking about causes, things that cause pulmonary hypertension.
hypertension.
Right. So these are things that if you have these things, you should or may be evaluated for pulmonary hypertension.
Correct.
Go ahead. I'm sorry.
So one is the heart functions of the left side of the heart we're talking about, where it doesn't pump well or relax well.
Okay.
Fluid sort of backs up into lung. People what we call pulmonary edema, congestive heart failure.
Right.
That's
I've heard that word before. Yeah.
And then you have the other group with lung disease, people with chronic obstructive lung disease.
Like COPD.
COPD.
Yeah, we've heard that.
You know. And the fourth one is people with blood clots that goes into the lung, right? They can also develop it. And the fifth one is a mixed bag, like sarcoidosis, sickle cell disease, thalassemia. All these different diseases can lead on to it. But the sort of group, because the first one, which is the group 1, they have certain pathological as well as treatment effect. And a lot of treatment is really concentrated on that. The others based on...
Okay. Let's step back just for a minute.
Sure.
Because I want to make sure we understand what you're talking about. When you talk about treatment, you're talking about actual medications that we may give as doctors.
Correct.
That may cause, a side effect of that medication may cause high blood pressure in the lungs or pulmonary hypertension. Is that where we're going?
No.
Okay.
What I was trying to get to is as far as how to treatment response.
Oh, I understand.
Which group benefits the most
from the treatments that we give.
So yes,
right.
So group 1
for
would
the
be
hypertension.
the one.
Right.
And the group 1, there's one that we don't know why it happens, called idiopathic pulmonary arterial hypertension.
Oh, that's a big word. Hold on.
Is it?
Idiopathic pulmonary hypertension. And it means that we don't know what the cause is, or idiopathic? Can you explain that one to me?
Exactly. We don't know why these patients develop. It happens sporadically.
Right.
It just happens. We don't, at this point, know exactly why this happens to these patients.
Okay.
And the second group is the people with family members that have it.
Okay.
Familial pulmonary hypertension. Then certainly, I'm sure over the last few decades ago, was kind of on the news on and off, was that diet drugs.
Oh yeah, that's right.
The things that were amphetamine-like medications were responsible. We had this big, sort of like an epidemic in a way, that people developed pulmonary hypertension. Then you have certain toxins like the rapeseed oil that was in Spain.
Right.
A couple of decades ago, and those are the conditions that can lead on to in group 1. The other conditions are people with cirrhosis.
Cirrhosis, you mean the liver?
Correct.
Liver cirrhosis, like people that overdrink alcohol that cause cirrhosis.
Yes.
Oh, all right.
And people with HIV can also have it. About 0.5% of the population can develop. Those with HIV can develop pulmonary hypertension.
Interesting. Very, very interesting. Now, the thing of it is that some of the symptoms that a person that has this problem would have. What are some of the symptoms that they may come about with?
It's the usual diagnosis, the usual symptoms, I would say, is really shortness of breath, especially on exertion. That's probably the earliest sign that these patients have. Okay. Other symptoms that people can develop is chest pain, and occasionally people pass out. That could be the initial symptom. For what happens quite often, these diagnoses are sort of delayed. People don't quite understand. It's not diagnosed immediately.
Right.
It might take some time, a couple of years, some people, till you find out this is what they have.
So when you say pass out, why would somebody pass out? Is it, hold on, should I think back on some of the things you've said? Is it because the blood slows up, and if it slows up, then it's not going to the brain and boop?
Well, it's somewhat, yes. No, I mean, that's about right. I think what happens is when you, like I said, when you get up and walk, exercise, run, do these things, you
Right.
got able to increase your cardiac output. That is, increase
Now,
blood flow
right. You're
through
over
your
my head
lungs.
here. You have to. Cardiac output is that amount of blood that is pushed out of the heart at one time with one contraction or pump.
Per minute. Yes.
Right.
Per minute.
Right. Okay.
So,
All right. So we got to keep that amount going. So if that slows up, then we have a problem.
Yeah.
Okay.
So I mean, I can give you an example. Like normal people have a cardiac output of 5 liters per minute.
Okay.
And if you get up and start exercising, you might need 10 liters per minute. So
All right.
in this case, that means I have to push 10 liters for me to do this particular activity.
Right.
But if my blood vessels are narrowed, I'm not going to be able to achieve it, and
Right.
puts the strain on the right side of the heart.
Okay.
And that puts the heart at a compromise where your blood pressure can drop, your heart rate can drop,
Oh.
and you'd pass out.
Right.
It is one of the symptoms that occasionally, as a consultant, I do see these patients for.
Mm-hmm.
And it's not always related to cardiac heart itself, but due to what's happening in the lung and what's happening on the right side of the heart.
Okay, all right. So I'm getting the sense here that the heart and the lung really work very closely together.
They're all connected.
They're all connected. Okay, I got you. What about as far as the swelling in the legs? And I know that's a big problem too. Why does the swelling of the legs happen?
A couple of reasons. I think because first of all, you have a low cardiac output, low blood flow going in.
Mm-hmm.
Your body senses this, and
Right.
the way it tries to compensate, just like even with other left-sided heart failure, what we typically call, is try to retain water,
Okay.
try to retain fluid,
Mm-hmm.
and that's what happens.
Okay.
So it's just a neurohumoral mechanism that causes you to retain.
The retain. So it's trying to hold on to fluids. All right.
Thinking that it's not enough volume there
Right.
because you're not getting it.
Because it's not going through, so the
Circulation,
right.
yeah.
The brain is saying, I don't have enough circulation, so I must need more fluid. So hold on to it.
Yeah.
Yeah. That makes sense. Is it more common in one gender than the other? Is it more common in males or females and males, or females or males?
It's got two answers to it.
Mm-hmm.
Yes and no.
Okay.
The first part, yes, it's absolutely true. It was really diagnosed mostly in young females.
Okay.
There was, it's about 2-to-1 proportion, 2-to-1 ratio when you're in let's say, your 30s.
Right. Okay.
When you get to the older age, sometimes we do see patients in the 70s and 80s. The age difference goes away.
Okay. All right then. All righty. What about as far as children? Can children get this disease?
Children have a couple of conditions that can lead on to have that, especially congenital heart disease.
Congenital means you were
You're
born with it? Gotcha.
People
All right.
People with hole in the heart,
Right.
what we call there's a septum that divides the chambers.
Mm-hmm.
When you have hole in there, you have problem like blood recirculating that leads on to pulmonary hypertension.
Gotcha.
Now, those people that have familial
You mean family
tendency,
history?
family history,
Right.
certainly they have it, but the diagnosis usually later on, usually into the third decade when you start seeing, more towards the later part of second decade and
Right.
third decades where these people are typically diagnosed. So you could see it on a younger population, but not so much in like kids as opposed to late teenagers.
Okay.
And early adults would be the most common time that we typically diagnose.
All right. In your practice, if someone presented in your office with pulmonary hypertension, how would they present? What would they look like as a patient that you would say, I think this guy may have pulmonary hypertension?
Well, I think quite often as a consultant I get it because a lot of tests have been done, they couldn't find it.
Right.
The typical patient has history of shortness of breath. They go through a variety of testing, and if you don't find what the cause, whether it's the breathing test, nothing quite points out
Right.
to what's causing it, and they wind up sending to a pulmonologist. Well, the patient's still short of breath. We're not sure why.
Right.
It's not asthma, typically in the younger population, and sometimes you get the older population. Well, sir, I don't think it's a heart disease, but can you look into it?
Right.
And the typical person usually short of breath. Now, I have just a few days, I think this week, I saw a young girl, had, as a child, had leukemia.
Oh.
Who did extraordinarily well. Now she's in her 30s.
Right.
For the last couple of months, she's had this problem, shortness of breath. There are times where she nearly passed out.
Right.
Now, she went through, initially they thought it was bronchitis. They treated for that, still didn't go away. I just saw her, and I don't have the diagnosis yet. I suspect this is one possibility. This would be somebody perfect, right? A woman in her 30s,
Right.
short of breath, prior to is very active, you know, who nearly passes out. She has occasional chest discomfort.
Right.
So kind of fit all the criteria. Certainly I'm doing the workup now, I would know it. But this would be one of those type of patients that we typically run into.
All right then. Do you emphasize the shortness of breath?
Yeah.
Are these the type of patients that you may see or may need oxygen support, meaning that there would be the ones that you would see with the cannula in their nose walking to support them with oxygen if they had a severe case of this problem?
Yeah, some of these patients do need it. Their oxygen level is low, and sometimes it gets lower when they exercise.
Okay.
These patients would need it. Matter of fact, oxygen would be one of those therapies that actually could help with their prolongation of life or decrease mortality. You know, it's been shown those patients that have low oxygen tension, you give oxygen, and really they looked at the number of hours they used and looked at the mortality over the 5 years.
Right.
The mortality rate is much lower.
Okay.
And those patients that use oxygen, that need oxygen, then use the oxygen.
Okay. So what we're talking about is oxygen is a key factor in a sense that our bodies need it to survive, period.
Correct.
And with this particular disease, oxygen can be low.
It can.
It can be low. So if we give oxygen as a therapy, as a medicine,
Yes.
meaning that give you a nasal cannula and that's what you walk around so that your oxygen doesn't bottom out on you when you exert yourselves or when you're climbing stairs or moving and grooving, then you may actually, studies have shown that you may actually live longer.
Absolutely.
Excellent.
And the other thing is you have to understand, conversely, if your oxygen level, in this case, the patient requires oxygen because we tested them, right?
Right.
Look at the patients that do have low oxygen. Okay, mind you, the blood vessels in your lungs,
Right.
hypoxia, in this case low oxygen,
Right.
causes pulmonary vasoconstrictor, which means it's narrowing of the blood vessels
Right.
because of low oxygen. So if you already have the disease, I don't think you want to make it worse.
Right. Right.
So in this case, you want to give the oxygen
Oxygen.
as
So
one
it
of the-
won't. So those vessels won't spasm.
You're not
and
causing
get-
additional
Right. Additional narrowing.
additional narrowing.
Right.
all
Right.
that.
What about when you sleep? I know that when we sleep, sometimes our oxygen dip. So these patients would have even a double whammy. Then you would
Yes.
really want to give it to them while they sleep, right?
I think all these patients have to be carefully evaluated.
Right.
You know, and sleep is one of the times we all sort of drop our oxygen level a little bit.
Right.
Most of us, and those people, certainly with sleep apnea, drop.
Right.
They
right.
actually
It
have
drops down.
drops. But people with borderline oxygen level in them, when they're resting, they're sitting up, the oxygen level will be okay. I mean, it's okay in the sense, not normal, but okay, don't need the oxygen when you're sitting there. But at nighttime, when that drops, it actually causes problems for them.
Right.
So we really look into it, and if they have oxygen drop, we would recommend, even if they're needed during daytime,
Right.
nighttime you might need it, and I
You
would
may
give
need
it to them.
Right. Let's go through some of the tests that we as physicians do to try to figure out what's going on. Tell me about this echocardiogram.
Okay. I think that's the first test that's typically used to find out whether this patient suspected to have pulmonary hypertension.
Describe what an echocardiogram
Right, it's
is.
gonna get
I
there.
said this big word, but we may not know what it is.
Yeah. It's an ultrasound of the heart.
Right,
Typically
ultrasound,
how
right.
the sound waves goes
Right.
in, you see the picture. You can see the actual heart moving,
Right.
you know. The initial evaluation is actually going to be looking at the chamber sizes. People with high blood pressure, remember I told you the heart has 4 chambers.
Right.
Right atrium, right ventricle, left atrium, left ventricle.
Right.
So one of the clues when we do the echocardiogram, we're going to see the right side of the heart, the right chambers, right atrium, right ventricle being dilated.
Right.
They might contract okay, but when you see the dilatation, we know there's something going on.
Okay.
From there, that sort of sets the clue. The other parts of the test, what they do as a part of complete echocardiogram, is looking at what we call Doppler velocities. We do a Doppler study across the valve between the right atrium and right ventricle, and we get this what we call velocity profile. These are sound waves that looks at the speed of the blood going through across the valve. And it is a formula that calculates or estimates what the right-sided pressures are.
Right.
So we were able to see that. So if anything suggestive out of the normal, because typically your right ventricular systolic pressure would be less than 40.
Right.
Yeah. Anything above that, we would, or even borderline to that, we would consider what does this patient have pulmonary hypertension. Certainly if you have the chamber size enlarged and so forth, these are all indicative. And that's where it sort of starts some of the process going forward.
Right.
Now, some patients earlier on might just have symptoms of shortness of breath, might not have some of these changes that's seen in the echocardiogram. And given everything else is okay, we sometimes would like to do exercise study on them.
Okay.
Have them exercise, and then just like we do stress echocardiogram to see if you have blockage in the arteries, we can measure the pressures before and after the exercise.
All right. Well, you know what, and unfortunately we're running out of time.
Okay,
but the thing of it is that we're going to have to close off right now.
Sure.
We're going to have to get you back, and we'll have to talk about this maybe a little bit longer and other topics.
Sure.
All righty. But we've run out of time. It's been so great talking with you, but we will have to close it down now. Dr. Anand, thank you very much for covering this subject. It was excellent, and we'll have to get you back.
Thank you.
All righty. Well, in closing, remember, sharing and caring. All right, guys? Listen, do something nice for somebody out there simply because you can. Share your med moments because it just may help somebody else, and it may stimulate them to go see their doctor. All right, never institute any change in your medical care until you see or consult your physician. I trust that each and every one of you have continued good health. Remember, go to the website, OBeyYourDoctor.com. Check us out. Until next time, peace to you all. All right.
Is that it?